Hi, my name is David, registered dental hygienist. Let's get ready to study Oral Path. I hope you have notes, a workbook, something to write your own notes in. I have the video here and you can pause it or take screenshots as you need to, but you're going to remember the best what you write down yourself. So get a cup of coffee or a tea, take your time, write it down, and you'll be thankful in the long run not having to repeat the video multiple times because you've already written it down and consolidated the information. Let's go through this. Oral pathology. What I want you to remember is oral pathology is not just about surviving the board exam. This is going to be one of the most essential services you provide to your clients. They're coming to see you more than their doctor, their nurse, or anybody else. So you being the first one to recognize a systemic disease can make the difference between life and death. Did you know leukemia, the first symptoms of it show up in the oral cavity? Wouldn't that feel nice to know? Someone came in to see you and you sent them right away to their doctor because you noticed the inflammation, you noticed the signs and symptoms, not to diagnose, but to know this is not normal. This could be indicative of many things. I'm not going to tell you what they could be because I don't want to scare you, right? But you should go see a doctor right away and then they get it diagnosed. I've already had the privilege of helping somebody who had their hypertension, their high blood pressure was not being managed properly. And because they kept seeing me and I kept taking their blood pressure, they recognized the meds aren't working. I need to go see my doctor, and they ended up in Emerge, getting help they needed. So your patients are counting on you to be their first line of defense. Let's go over the basics. This may seem redundant, but the better you are at the vocabulary, the basics, the easier it will be to do the really hard case studies. Many students will say, oh, just give me a big, long case study. I need more practice with a case study. Well, case studies are hard because there's a lot of words we don't use every day. But once you become familiar with these words and you've mastered them, it's a second language. You're basically just learning some Greek and Latin. Once you've done that, you can just read through those case scenarios very quickly to realize all that they're saying is there's something white and raised on the tongue. Once you do that, you can realize all they're saying is there's something big and white raised on the tongue. Let's go over some basics. A macule. I think of an M&M candy. M&M. Why? M&Ms are kind of like a flat candy. It's like melts in your pants, not in your hands. So I think of an M&M. Less than 1 centimeter. Freckles, an amalgam tattoo, little spots. We all have macules. A papule, now it pops out. That's how I remember it. It's popping out. Again, less than 1 centimeter, but it's sticking out. Lots of things could be sticking out. But that's how we're describing it. It's a papule. A nodule, now it's an elevated lesion. And look for that. Sometimes the words may say raised or elevated. Or in the case of a macule, it might say a non-elevated lesion. You have to be familiar with many ways of saying the same thing. So it's raised, but it's greater than 1 centimeter. So it's not a papule anymore. It's a nodule. And it's hard. It's firm. Feels like a marble. It's deeper in the dermis. A vesicle, less than 1 centimeter, and it's clear. It's fluid-filled and it's clear. It's serum or blood that's in there. A bulla is like a vesicle that dreamed of being something more. I want to grow up. I want to be a bulla. That's what a vesicle decided. So it's greater than 1 centimeter, clear. It may have hemorrhagic fluid, maybe a bit more red or pink, a bit more blood in there. An ulcer is an open wound. There's our little skin layer, there's our ulcer, it's open. We don't get them on our skin, we get them inside our mouth on non-keratinized tissue. Because if it's keratinized, it scabs over, doesn't it? You cut yourself or you get a rug burn or something, you fall off your bike, whatever you're doing, it doesn't just stay open and oozing all the time, it scabs over really quickly. But not in the mouth, not on non-keratinized tissue, which is why you can get ulcers in your stomach and your colon. painful. Erythema, that just means it looks red. Leukoplakia, that's going to be white. So those are some basic terms. In here, one we missed, but it's relevant, is going to be the term pustule. And what is it? Well, it's like a vesicle, but this one is now pus-filled instead of just clear fluid. What that means is it's left with the remains of the war that happened under your skin. Your white blood cells fighting the bacteria, and these are the casualties on both sides. It's full of pus. That's what it is. So if the board exam says, how would you best describe this lesion on the mouth, and they show you something sticking out, the option might be papule. If it's really big, you might say, oh, that's going to be a bulla. Or if it's clear and it's small, you might say, oh, that's going to be a vesicle. If it's not raised, it's just smooth, then we're saying it's a macule. A macule that gets larger than 1 centimeter now becomes greater than 1 centimeter. It becomes a patch. So macule is to a patch what vesicle is to bulla. A macule is less than 1 centimeter. When it grows up, it becomes a patch. I got a patch on my arm. A vesicle starts off small. When it grows up, it becomes a bulla. Descriptive terms of oral lesions. Pedunculated. It's sticking out. I like to think of like a pea. Because the letter P is kind of like a little stalk. It's sticking out. Pedunculated. It sticks out like a mushroom. Sessile. This is sessile. This is smooth. And what are we talking about? We're talking about the lesion or the growth in relation to the tissue it's connected to, whether it's in your mouth or outside. Is if this is your skin, is it sticking out like this and this is the growth, it's pedunculated, or if this is your skin, does the growth go like this? And it's smooth on the borders. That's sessile. Remember, this isn't a diagnosis. These are descriptive words. So when we write it in our notes or refer to another doctor, we can say we're concerned about a sessile 1 to 2 millimeter lesion at this location. We're describing it. Lobulated. You can think of this as a bunch of grapes. Does it look like a bunch of little grapes clustered together? Or is it just nodular? It's just one. You can expect this to be asked of you when describing a torus palatinus. So at the top of the mouth, they might just show you a torus palatinus, and they would say, which of these words best describes this lesion? Is it lobulated or nodular? Is it just one? Or is it a bunch? If it's a bunch, it's going to be lobulated. If it's just one, you would say nodular. Ulcerated, we talked about that. It's an open wound. Papillary, now it's like, well, it's nodular, but it's like it's just one growth, but on the surface, it's got a bunch of little finger projections. Okay, it looks bumpy like that. That's papillary projection, often described as cauliflower. Exophytic. Exophytic means, exo means to grow out or exit. Growth. It's growing out. So this is going to be, most of our lesions we're looking at grow out of the mouth. Endophytic. That's growing into you, which is more dangerous. Obviously, we have to remove something. It's easier if it's growing outwards. We can grab it, snip it, cut it, freeze it, laser it, however you have to get rid of it to excise it. But if it's growing into you, that's more extensive, isn't it? If what we're seeing on the surface is just the tip of the iceberg, and it's going deeper into your connective tissue or your muscle or other problems, to cut that out is going to cause a lot of damage. Erythematous, that just means red. Sorry, going back. So exophytic is most likely going to be benign. Endophytic is most likely to be malignant. If I got something growing on me, yeah, grow out. That's fine. You're not going to harm the rest of me. But if you're growing inside of me, then obviously it poses a greater risk. These are the words with more description to go with them. Take a screenshot, but make your own cards. That's what's going to help you the most. Pedunculated, it sticks out like a squamous papilloma, it's popping out. A sessile, like a fibroma, which is scar tissue, that's going to be more smooth to the surface epithelium. Exophytic, that's going to be like a pyogenic granuloma, it's growing outside of you. Endophytic, that's growing inside of you. We covered that. We talked about lobulated. We talked about nodular. We talked about papillary, little finger-like projections. We talked about verruca vulgaris. Actually, we haven't talked about it. We're going to talk about it now. Verruca vulgaris, vulgar means common language. So to speak vulgar language, that is a reference of you're speaking the base language, like sailor talk. Don't use that vulgar common language. It's not civilized, or really it's offensive. But with medical terms, it just means the common of what? The common verruca, the common roughness. Then we have pemphigus vulgaris, the common blister. So just think common. Ulcerated, we talked about that. Fluctant, that means fluid. A fluid-filled lesion. So a vesicle would be an example of a fluctuant lesion. Indurated is hard. We could pop it with a pin and nothing's going to squeeze out of it. It's indurated. More suspicious for malignancy. Possible squamous cell carcinoma. You need to know this. If something is firm and raised, they might not use the word firm. They might just say, a raised indurated lesion is found. Is that a nodule or a vesicle or a bulla? They expect you to know that firm or indurated can be used interchangeably. So that's what I want to think of. It's going to be probably a nodule. Versus, they might not say a fluid-filled. They might say a raised greater than 1 centimeter fluctuant lesion is found. Fluctuant papillary or papilla. Cut. They might expect you to know that you find papule. They might expect you to know this 1 centimeter papule is fluid-filled. This 1 centimeter papule is fluctuant. You have to be able to speak both languages and understand what they're really talking about. This is fluid-filled, so mucocelli would be 1. That's like a salivary gland trauma, like a tumor starts swelling up in the mouth. Erosion. That's a shallow, superficial lesion. It's not going through the connective tissue, it just exposes the connective tissue. The aphthous ulcer in the early stage is an example of early erosion, right? Fissured. This has to do with a folding or a crack. So usually in response to trauma, the tissue starts making more of itself to protect you, like extra padding in the bottom of your feet or in your gums or on your cheek when it's being irritated. Then it starts to grow extra and it folds in on itself. You can see it's fissured. You can also have a fissured tongue, like a crack right down the center of your tongue. Expected on the board exam. They show you a picture of a tongue with a crack. What word best describes the center of the tongue? Fissured, erythematous, hyperplasia, hypoplasia. They want you to know fissured. It's got a crack in it. Let's circle back one more time to indurated or fluctuant. This is going to come over into your study of lymph nodes and oral cancer screening. You're feeling along the SCM, the sternocleidomastoid muscle. You're feeling along there and you noticed a growth that is indurated, non-tender. Or you notice a growth that is fluctuant and tender. What's a greater concern? Would you know? Is it better if it hurts or better if it not hurts? Is it better if it's squishy and fluctuant, or if it's better if it's indurated and hard? Well, if your body's fighting an infection, you can think, I'm sick, my body's swelling, making extra fluids, trying to drain away the damage that's been done while new white blood cells are waging war on whatever's attacking me. It's probably tender. But if I just have an out-of-control growth of cells, which is what cancer is, it's just uncontrolled cell growth. It's the simplest way of describing it. It's probably not going to hurt, and it's going to be firm. It's not going to want to move around a lot. We're more concerned about malignancy when we see that. Blanching. This means to turn white. Take your finger, squeeze it. See how it turns white? That's called blanching. My finger blanches upon bidigital palpation. Using my finger and my thumb, I squeeze it, it turns white. That's good. That's like saying there's water going through the hose. I step on the hose and water starts coming out. That's what it's supposed to do. So if the lesion blanches, that tells us something about it. If it doesn't blanch, that tells us something else. Would you know which one between a hematoma and hemangioma blanches upon pressure? You will at the end of this video. Stay tuned. Erythematous, it's red. That's self-explanatory. Radiolucent, lucent means, when you see the word lucent, lucent means clear. There's a car company that called themselves Lucid Air, like clean air. To elucidate means to make clear. So we have a lucidum layer in our skin, in our palms, and the soles of our feet, a clear layer. So radiolucent, radio clear, radiographically clear. So that will look black on a radiograph, won't it? The x-rays went right through that tissue. It wasn't stopped by bone or any calcified tissue. It went right through, so it's clear, radiolucent. Why is this important for oral path? Because cysts, abscess, soft tissue lesions, giant cell granulomas, anything like that, is not calcified in your mouth. It will look clear. So it may start interacting with the bone. The bone starts wearing away because it doesn't want to get infected, or it actually starts just eating away at the bones. We take a radiograph and we see, oh, we're seeing a little radiolucency cupping around this area. I wonder what happened there. Well, it's going to be maybe one of these pathological conditions. Radio-opaque, that's going to look like you can't see through it, right? It's dense. It indicates a structure. So if we see a radio-opaque marking or lesion or finding on a radiograph, what is that likely to be? Is that going to be a cyst, an abscess, a giant cell granuloma? And you're thinking, what on earth are all those things? You just need to know those things are soft tissue growths. They're not going to be radiopaque. You're going to see through them. But bones, an osteoma, bone growth, or tori, of course, that's bone. You're not going to be able to see through that. That's what I want you to take away from this section in oral path, knowing that soft tissue lesions are radiolucent, hard tissue growths are going to be radio-opaque. Quick tip, for those that helps, pedunculated, you can think like a post. Sessile is smooth. I think of sitting flat. And I like the way, you put an S on a flat line, it kind of blends right in, doesn't it? Versus a P stands out. Benign oral lesions. Irritation fibroma. What is that? Irritation is the cause. Fibrous, then oma is growth. What is that with fibrous? Think collagen. So a repeated irritation, whether that's a denture that doesn't fit right, or you got braces on, you constantly irritating, or just your own cheeks, just biting your cheek over and over again. That causes your body to make more collagen to defend yourself. I don't want the nerves to be hurt. Knock it off. You don't knock it off, fine. I'll make some collagen so you can go right back on to ignoring me and destroying your body, right? That's what your body's kind of responding to do. So it can look like a lipoma, which is just a benign adipose tissue growth, like harmless fat growing on you, okay? It's near the line of occlusion, but what makes you think it's a lipoma and not a fibroma? Usually location. Both are going to feel a little bit firm, a little bit squishy. They're both pink or raised. You can push on them. But fibroma is caused by irritation. Do you see a reason why that area would be irritated? Then it's probably a fibroma. If there's no reason for it to be irritated, it's on the floor of the mouth, or it's in a place that doesn't see a lot of irritation, it could be lipoma. It could just be fat. Anyway, you would go to the doctor and they would look at that and see if excision is necessary. But both reoccurrence is very rare if the cause is removed. You might be wondering, but I thought linea alba was the white line on our cheek when with chronic cheek biting. Is linea alba just a form of traumatic fibroma? Answer, no, it's a different thing. Why? Linea alba is an epithelial change, just the epithelium. A fibroma is a connective tissue change. A linea alba is going to be keratin, a keratinosis of that epithelium. The top layer responds by putting more keratin. It's now tougher skin. A fibroma is the connective tissue that says, let's make a whole lot more collagen. If you have a scar, you notice they always look white because the melanocytes can't really penetrate or get through that collagen. And it's kind of painless. You could take a pin and you can poke around, but if you actually poke right on the scar, it doesn't feel as much. Why? There's no nerves in that. It's just a bunch of collagen. So that's how we're looking to notice the difference. Linea alba, again, it's harmless. It's just friction or pressure, but it doesn't go as deep. It's just on the epithelium. So is a fibroma scar tissue? Yeah, you can just call it a scar. It's like a ball. That's like a ball of scar tissue. The body keeps laying down collagen to repair irritation. That's why sometimes you may see a fibroma called a focal fibrous hyperplasia, which is a big fancy word to basically say focal, it's in one spot, fibrous, collagen, hyper, more of, plastic, make. Right? So it's a spot of collagen. Hyper means more. Plasia, think plastic. To make. So if you want to sound really smart, at school, you just tell people, oh, I've noticed this person has a focal fibrous hyperplasia. And everyone will look at you like, what on earth did you just say? All you said is there's a little spot where extra collagen's been put down. That's really all it is. So what is the linea alba? It's just a Latin. Alba means white. I think of Albus Dumbledore. Remember that? Albus, alba, white. Linea, from line. Oh, isn't that nice when our English resembles Latin and it's easy? White line. So fibroma, a scar lump, linea alba, epithelial keratosis. It makes more keratin. Keratin makes our epithelium waterproof. So you can think of it as like a tough rubbery layer inside, and what that does is it stops things from going through the skin one way and stops things from the other way. Basically, it's a two-way stop. If something is non-keratinized, then of course fluid and nutrients can flow back and forth easily. Most of the tissue of our mouth is keratinized a little bit. Some tissue has no keratinization at all, and that would be the circular epithelium between your gums and what's actually touching your teeth, that little pocket there, what you're slipping the floss down. There's no keratin. It's non-keratinized epithelium. Why? So nutrients can freely pass through your gums into the periodontal ligament area. That space. It's giving nutrients to all those fibers and the cementum. Everywhere else, you have a little bit of keratin, but we'd say non-keratinized for the mouth, for the oral cavity, in like under the tongue, the floor of the mouth, and we'd say keratinized for the tongue, your hard palate. But even the things we say are non-keratinized, they still have a tiny bit. But under the gums, there's none. But for the board exam, just think this. If it says what part of your gums or your mouth is non-keratinized, just think non-tough. Where would it hurt to get like a potato chip or a Dorito chip or something that's like, oh, you bite on it, it hurts? If it hurts, it's probably a non-keratinized tissue. If it didn't hurt and it's tough, like your attached gingiva, your hard palate, it's probably keratinized. Time to talk about fibroma and linea alba. Nope, we just did. Let's talk about neurofibroma and schwannoma. Let's talk about neurofibroma and schwannoma. These are basically the same thing for the board exam purposes. They're different, but all you need to know is a nerve has been hurt. That's with the nerve, right? Nerve growth. Or schwannoma, that's the sheath around the nerve. That's this protective layer covering has now grown. So usually the tongue, you bite your tongue. It's slow growing, painless. It can be visible on radiographs if it does what? Affects the bone. Now, as we talked about before, if a neurofibroma or a schwannoma is affecting the bone, will that appear as a radiopacity? Will it look radiopaque? Or will it look radiolucent? Lucent, clear, right? It isn't added bone, it's taken away bone. So you can be treated with surgical removal. What's a melanocytic nevus? Melon, that's the things that make color in our skin. Melanocyte. Nevus, birthmark. Birth. A benign tumor of pigmented cells. It's like all the little melanocytes got together and had a little hug, and they stayed together. So it looks like a little mark there. It's an oral lesion usually found on the palate or buccal mucosa, usually small and dark. It can be flat, which would be a macule. It can be slightly raised. That would be a papule. Good. Brown to black spot. Classified by its location. Here's the important thing to remember. It can look like melanoma. Melanoma is a bad cancer. So when we see a melanocytic nevus, we want to take pictures. We want to make good recordings of describing it, the millimeters, the dimensions, the color, the location, so we can watch it. Any changes in color, any new things, we need to refer for evaluation. Let's talk about oral squamous papilloma. In your mouth, flat papilloma. It's popping out and the oma tells you it's benign, versus carcinoma would tell you it's malignant. So it's caused by HPV, seen across all kinds of ages. What I want you to think about this is it's a wart. It's a wart-like, it looks like that, but it's not a verruca vulgaris. A cauliflower appearance. It pops out and it's got a little papillary surface on it. That's what I want you to remember. Little bumps all over here. It could be white to pink, usually less than, half a centimeter. It looks like verruca vulgaris, but it's not. That might be one of the most important things of this entire video. Verruca vulgaris, remember verruca just means rough. Vulgaris means common. Again, HPV, don't memorize the numbers. That's not important. Again, we have a rough surface, but what does it matter? This is more contagious. Contagious, and it's on the skin and mouth. Whereas the papilloma is only in the mouth. So here's a little comparison chart for you. You can see it's not very contagious. Yes, the wart is contagious. We're all warned about making sure we have some type of sandal on in the showers in a public bathroom. Cauliflower-like growth, it's rough, keratinized, nodular, but this is in the mouth. You can see this papilloma, all in the mouth, whereas this is going to be in the hand, the skin, and the oral cavity. So here's a little infographic that you can remember this by. Papilloma, Both are HPV. Don't memorize the types. Not contagious. Verruca vulgaris is contagious. Small cauliflower-like projection. This is rough. Verruca vulgaris can come back. A papilloma is unlikely to come back once it's cut out, once it's excised. So remember, papillomas are only in the mouth. That's the key thing. So if they decide a lesion that's growing out of the mouth, about 2 millimeters, a papule that's sticking out and it's on their cheek, is it likely to be papilloma or verruca vulgaris? You need to be thinking, papilloma is only in the mouth, therefore it's verruca vulgaris. However, if they say you're seeing the same lesion, it's kind of a rough surface, pink to white, and it's inside the mouth, now they want you to know if it's papilloma or verruca vulgaris. We want to see, do they have warts anywhere else on their body? If they do, then probably they transferred it from their hand or wherever it was, and they put their hands in their mouth because we're always touching our face. And that's how they got it. So it's more likely to be a verruca vulgaris. But if they don't have any lesions anywhere else, it doesn't mention nail biting, then we're probably thinking papilloma. Now we're going to discuss hemangioma. First we have heme for blood. Angie, that's going to be vessel. Oma, growth. Blood vessel growth. So not to be confused with hematoma, which is just blood growth. Don't confuse the two. That will come up on the board exam. They might have you pick. We're seeing a swelling or a growth. Is it a hemangioma or a hematoma? So this is blood vessel, usually from birth. You're born with extra blood vessels, or it can develop by trauma. You injured yourself, and now you have this extra proliferation of blood vessels there. The tongue is most common, and that makes sense. You're biting your tongue. It could also be your lips and cheeks. So they are capillaries. Keep this in mind. This isn't like a zit or something you can pop and drain. When you think about it, it's like you look at these little red spots, and as you get older, you start getting cherry angiomas. I have some. Most people have them. And you think you might poke it with a pin and drain it. It just bleeds like crazy. But when it scabs over, it just comes right back. You haven't gotten rid of it because the blood vessels are there. That's like seeing a puddle on your front lawn and thinking, well, if I can just drain it, it'll go away, but only to discover you have a whole bunch of garden hoses, like from 5 different neighbors' houses, all going to your lawn. Well, it's going to come right back. Let's talk about understanding the word Angie, because it comes up a lot in several questions. So the more you can learn to speak Latin and Greek, at least in medical purposes, the easier it will be to answer these board exam questions, because you're going to be stressed out. They give you all kinds of big words, and if you can just decode it, you can figure out what they're talking about. So Angie means vessel most of the time. So angioma, vessel, tumor. This could be a benign vessel, like it could be from your lymphatic system, or it could be from your vascular systems, your bloods. Hemangioma, we talked about that, blood vessel tumor. We also have Angie for angiotensin, angiotensinogen. This is blood vessel tension. But now let's talk about Ludwig's angina. Angina does not mean the same thing here. Angie here means to strangle. So when we're talking about a choking, what we're talking about is an infection in the face where you start to have a cellulitis. The cells start multiplying rapidly from the bacteria, the infection, they swell up. And what happens is that you actually choke because of it. It actually crushes your windpipe. You can't breathe, and they can suffocate. Or they go systemic. So how is this happening? Normally you get an infection in the mouth, we're tracking it through the lymph nodes. We're looking at first the mental, submandibular, the deep upper cervical. We're feeling along the neck, right, the sternocleidomastoid mastoid. We're tracking it as it goes from checkpoint to checkpoint. This is more like someone just took a blimp over the border and skipped all the checkpoints. It's sliding between the connective tissue and the muscle and proliferating there, and your cells react. So it can swell up like a bullfrog. Where does this come in for our purposes as dental hygienists? Oral piercings. Anyone can get Ludwig's angina. Like, it's just an infection in your mouth. But if you have a piercing in your mouth, you have an open door for bacteria to get into that space. Someone with an oral piercing, we do need to make them aware of how it may affect their dentition. But more importantly, we need to make sure, have you heard of Ludwig's angina? Are you aware of what you should be looking for? Why? Because it happens so fast. It can be hours. It can go from a small swelling to death. So it's a medical emergency. If they notice the swelling, they don't need to book an appointment with us. They need to go to emergency. So we're going to see a tongue swelling, submandibular swelling, bilateral on both sides, difficulty swallowing, that's called dysphagia, like a macrophage, a large eater. This is dysphagia, problems eating. Let's talk about trismus, difficulty opening your mouth. This is when the cells have grown so much that it's actually interfering with your jaw being able to open, a bit like you put a bunch of clothes in your backpack and things behind your door, you can't open your door anymore, okay? That is what's causing trismus in this case. Trismus just means difficulty opening the mouth. There could be multiple reasons. Your jaw could just be sore. Your muscles are tense. On the board exam, be looking for this for local anesthesia. Someone came in yesterday for an extraction or a root canal or for periodontal debridement on a sensitive area, and local anesthesia was given. The next day, they report their muscles are sore. They have difficulty opening their mouth, or they report trismus. What should be done? Should they come in? Do we just use a heat and compress and take some painkillers? If things don't get better after 3 days, come in. What do we do? The most important thing is for them to come in and see you. The reason why is we don't know if the muscles are just sore or if there is bacteria multiplying there and your cells are reacting and becoming inflamed. You can look up in Darby and Walsh, and it says, after 2 days, the dentist must treat it like a bacterial infection and prescribe antibiotics. In the meantime, they need to come in right away. The dentist may look at them and say, I think it's fine. I don't want to do antibiotics yet. Do a heat compress, massage it. Let's wait till tomorrow. If it's not better by tomorrow, come in again. That is probably what they will do. You will look in Darby and Walsh. You will see that is the requirement. So expect it on the board exam. Well, it may say, what's the best option? Should they come in? Should they come in plus do a heat compress or painkillers? Obviously, adding painkillers, heat compress, chewing gum to massage to get it working, that's a great addition. But the bare minimum is to come in and be evaluated by the dentist. That's any difficulty with trismus. So with angina, we do have trismus, difficulty opening the mouth. You can have fever and malaise, just not feeling good. So we need an immediate referral. This is a medical emergency. If your patient reports having a bilateral swelling, it's difficulty swallowing, they need to go to emerge, not you. Tell them, as you have this piercing, that's your choice, I respect that, but you need to be monitoring for this. If you feel any difficulty swallowing, take a look, feel around. Is it hard to swallow? You need to go to a doctor and be evaluated right away. So we looked at this. Angie is vessel. Ulma is a swelling or tumor. Hema is blood. Angina for strangling or choking, not blood vessel. That's why we have angina pectoris, right? A choking in my pectoris muscle area. So let's look at the main difference between hemangioma and hematoma. This again could very likely come up on the board exam, and you're looking at, what am I picking here? Someone is given a PSA injection to anesthetize their 1/7, and now we're seeing a red swelling about 1 to 2 millimeters in diameter. Has it always been there, or did it just develop? You can't be sure. You just notice it. You don't remember if it was there before. Is it a hematoma or hemangioma? And what do you do in each case? So with a hematoma, it's a blood puddle. You have a bunch of blood that's growing there. Hemangioma, it's blood vessels. Blood vessels are there to stay unless you get some type of laser treatment. You talk to a dermatologist about that. A hematoma is just blood that's pooling there. You can think of it as something like a bruise. A hematoma is going to be sudden, obviously. Hemangioma is going to be gradual, a slow onset. You don't get a bump on the arm or in the mouth and a bunch of blood vessels start growing. That doesn't make sense. Hematoma would. You get hurt there and the blood vessels start leaking. It can happen at any age. Hemangioma is mainly infants and young children. This one will be softer. It's fluctuant. It's fluid-filled. Hemangioma is compressible, but here's the key thing. It's got blanching. That's the important thing to remember. If I press on it, does it blanch? Press your finger, so it goes white. You're squeezing the blood vessels so no blood can come out. If we can push on it and it turns white or goes back to pink, we're looking at a hemangioma. You don't need to put pressure or ice on it or do anything. It's just a hemangioma. If, however, we press on it, it doesn't go away. It's tender. We're looking at a hematoma. Now, for 10,000 points, what do we do for a hematoma? Are we trying to incise and drain? Are we trying to pop it? No, you know that. Are we putting heat on it? Are we massaging it? What are we doing with it? It's blood leaking out of the capillaries. I want you to think of any war movie or medical show. Quick, they're bleeding. What do we do? Put some pressure on it. It's like right on the tip of your lips. You're going to say, yeah, put some pressure on it, right? You're putting pressure on it to stop the blood from coming out so a blood clot can form. What do you do with the bleeding nose? What do? You squeeze. Go down. Don't let go of your nose for 10 minutes. Don't check. Otherwise, the blood clot will just burst open again. We need pressure. So that's it. Think about this, though. Think about the board of questions that could arise from this differentiation. A hematoma versus hemangioma. It may give you both options. What are you seeing and what should you be done about it? And you may look at them and think, they both sound so similar. Is it a hematoma or hemangioma? Oh my gosh, I don't know. Just think hemangioma is blood vessels. If the board question asks you, it's just showing a red swelling there, this many millimeters, assume it's something new. Don't assume it's always been there. If it talks about local anesthesia was given, then assume we're putting pressure on it. No heat until the next day. Heat, you put pressure, then cold. Okay, that's Oral Path 1. I hope that was helpful to you. I'm posting new videos like this all the time as I can find time to do it. Remember, online at rdhblueprint.ca, I have free quizzes, free PDFs for you to try these out. And if you like it, you can buy more. I want to equip you for the Canadian board exam so that you are ready. And thanks for watching. Bye.